Seerat, Seerat, your voice is not audible. You need to close the this Google Meet. Yeah, it's audible now. Yeah, it is audible now. Your voice is not audible. You need to close the this Google Meet. Yeah, it's audible now. Yeah, it is audible. Seerat, you need to disconnect your Google Meet and start from beginning.
Now is it audible?
Now is it audible?
Now is my voice audible? Please let me know in the comments. I don't want much delays. audible now? Yes, I have got a response. My voice is audible. Let me start with my brief introduction. I am Dr. Seerat Punj, a practicing clinical dentist with a keen interest in academics too. And today in this session, we'll be discussing about the previous year recall questions of 2024 MDS. And today in this session, I won't just focus on the correct answers and their explanations, but I'll also explain the incorrect ones, that why they are wrong. This will help you understand the concepts better and avoid the common mistakes in your upcoming exams. Actually, students, you never know what examiners might come up with in your next exams. Sometimes they may twist a previous year question and frame a new question from the wrong options only. That's why we need to be fully prepared and understand every option, each and every option better, not just the correct one. So let's get started. Let's get started with our today's session. The very first question is on your screen. The image shows multilocular pathology. The multilocularity is caused by septae within the pathology. What is the cause of these septations? Yeah, they have given a very beautiful radiographically representation, and I'll be explaining through this representation only. Here you can see a multilocular pathology near the molar. First locule, and here is the second one. In between you can see these septas. Yeah, students, what are septas? Can anyone answer in the chat box? What are septas? This way we can interact in the class, students. I'll also develop a keen interest to teach you that yes, my students are responding. So, yeah, I'll explain you. What are septations? They are nothing but a simple separations, a simple boundary. Yeah, a simple boundary. Nothing else. Don't go by any bookish definitions. It will cause a problem in your exams only, nothing else. Just remember, septations are nothing but simple boundaries. Simple boundaries. Yeah. So they are asking about what is the cause of these septations. The options are formation of new bone within the pathology, entrapment of normal bone within the pathology, metastatic calcification, and fourth option is none. So I'll explain you what actually happens. Yeah. So here we have our mandible. Don't go on my drawing, it is really poor. But yeah, I'll try to explain in a best way I can. Yes, it is mandible. And so what happens in a pathology? What happens in a pathology? The bone starts resorbing. Here, the bone starts resorbing. Some part of the bone, of the old bone, does not get resorbed. Some part of the old bone only does not get resorbed. It gets trapped in between the, yeah, I'm drawing with my yellow marker. It's an old bone only. It's an old bone only. The green marked area, the area marked with the green was a pathology. The yellow area marked with the boundaries marked with the yellow marker is the old bone, which got entrapped between the pathology itself. It is not the new bone which is formed within the pathology, but it was the old bone which got entrapped within the pathology bit because it wasn't resolved yet. So the answer is clear. The answer is second option, entrapment of normal bone within the pathology. So let's learn each an option very well. Coming to the next slide. So can you answer, I'll go back to my previous slide only. Can you answer some examples of multilocular pathology? Students, please interact with me so that I should know that you are understanding my concepts better. I need response. I could see the students joining the sessions, but they are not responding in the chat section. Can you name some multilocular pathologies? Yeah, I'm waiting for you all. If not, then I'll answer it. Yeah, in many multilocular radiolucent lesions like ameloblastoma, OKC, odontogenic keratocyst, these septations are caused by entrapment of normal bone as the lesion expands. These septa give the lesion its soap bubble or honeycomb appearance. Mark this. Take a notebook with you and jot down the points in your notebooks as well. This may not be a question of the 2024 paper, but it can be one of your question in your next 2026 paper. What is the radiographical appearance of your multilocular cyst? Soap bubble or honeycomb appearance. Third point is, it's not new bone formation, but rather residual bone that hasn't been resolved yet. Got it? So, the next question is, I hope I've made my part clear. The next question is, a 19-year-old girl. A 19-year-old girl. Mark the points, highlight the points which you have to consider during your answering. A 19-year-old girl. Sometimes predilections is very important in attempting some questions. A 19-year-old girl shows horizontally impacted third molar. Impacted third molar. There is a 1.5 mm radiolucency around the crown of the tooth. The important word is 19-year-old girl, a young girl. Horizontally impacted third molar, right? And with a 1.5 mm radiolucency around the crown of the tooth. They are asking about what is this radiolucency. The options are dental follicle, dentigerous cyst, ameloblastoma, and the radicular cyst. Let's see the options one by one. Basically, what they're trying to ask is, here we have molar. A radiolucency is seen. A radiolucency is seen around the crown of the tooth. I hope my diagram is clear to you all. They are asking about this radiolucency. The question mark is here. What is this? Third option, ameloblastoma. We have seen in the previous slides, in the previous question, first question itself, it can be seen anywhere in the mandible. Anywhere in the mandible. Not just around the impacted third molar tooth. Got my point? So just eliminate it from the options. First thing you should do is eliminate the wrong options. Just eliminate the wrong options. Yeah, ameloblastoma is deleted from my options now. Coming to the next option, radicular cyst. What is radicular cyst? What happens around a non-vital tooth? In routine dental practice as well, you can see sometimes a pathology seen around the non-vital tooth, which is no more vital, giving us symptoms of TOP. tender on percussion, but not any signs of sensitivity. This cyst around the, I think my screen is not visible. Can I get some responses in the chat box? Yeah, it is visible now. This pathology seen around the apex of the root in a non-vital tooth is nothing but a radicular cyst. But they are asking about the impacted third molar. They are not saying about anything about the non-vitality of the tooth. So eliminate this as well from your options. We have only two options left with ours. The first one is dental follicle and the second one is dentigerous cyst. Now let's discuss about these options. Dental follicle. This is normal structure. A small sac of soft tissue around the crown of an unerupted tooth. On X-ray, it appears a thin radiolucent line around the crown which I have drawn. And please note it, up to 2 to 3 mm it is considered normal, and if it is greater than 3 mm, consider it as some pathology, and pathology like dentigerous cyst only. I have mentioned it. Yeah, if you see a radiolucency less than 3 mm around the crown of an unerupted tooth, it's likely a normal follicle. But if it is greater than 3 to 4 mm, suspect a cystic or a neoplastic change. Suspect a cystic or a neoplastic change. Dentigerous cyst. This is a pathological cyst that forms around the crown of an unerupted tooth like a third molar. Yeah, you can get confused during your exams between the dental follicle and a dentigerous cyst, but they will mention you about the size of the radiolucency seen. They will definitely mention about it. If it is mentioning about less than 3 mm, then go for the option dental follicle. And if they are given the measurement of about greater than 3 mm, around 4 mm, then go for the option dentigerous cyst. It is painless. It causes painless swelling. It can expand the bone and can displace the teeth. But these symptoms are not seen in dental follicle. It is normal. Ameloblastoma, as already discussed, appears as a multilocular radiolucency, not limited to just crown. It can be seen in the posterior mandible. Radicular cyst, this is the most common cyst in the jaw. It forms at the apex of the non-vital dead tooth, not showing any symptoms of sensitivity, just showing the symptoms of tender on percussion. It's not associated with crown of unerupted teeth caused by long-standing dental infections. I have captured some photographs for better clarity. Here you can see the radiolucency over the impacted third molar. Yeah, it is what? Dentigerous cyst. But don't get confused, they'll mention about the size. They'll definitely mention you about the size. Here, already endo-treated tooth, got non-vital. So this option is radicular cyst. Now we have any cyst, multilocular cyst anywhere around the mandible. This is ameloblastoma. You have to learn each and every option. Third question. Sorry. If a well-stored X-ray film processed, what will be its appearance? Completely black, cloudy with a blue tint, clear with a blue tint, and completely clear. Give me a minute. I have sore throat today. Yeah. Completely black, cloudy with a blue tint, clear with a blue tint, completely clear. So, a well-stored, unexposed X-ray film, when processed, will appear clear with a blue tint. Because why? It was never exposed to light or X-rays and is now just a transparent film base. Just a transparent film base. So the correct answer is clear with a blue tint. Coming to the rest options, completely black. It happens when the film is exposed to light or X-rays before processing. The silver halide crystals are fully activated, so the whole film turns black. So can you please tell me what are silver halide crystals? It is nowhere on the screen. I need response from you all. This will help you in preparation very better way. Yes, this will help you in preparation if you will interact with me. If you have any doubt, just raise your hand, just comment in the chat box. I'll explain you. This will make learning much easier for you all, even for me as well. Yeah, completely black happens when the film is exposed to light or X-rays before processing. The silver halide crystal, what I was asking about, what are silver halide crystals? Got no response, but I'll tell you. Silver halide crystals are nothing but a light sensitive components in the X-ray film that captures and stores the image when exposed to X-rays. They are crucial for forming both the latent and visible radiographic image. They are light sensitive components. So here what happens is the silver halide crystals becomes fully activated, so the whole film turns black. The next option is cloudy with blue tint, not a standard or an ideal result. May suggest a poor washing, improper fixing, leaving chemical residue on the film. Nothing can happen. Could look foggy or unclear. Yeah, this is our right option. Clear with a blue tint. This is what a properly stored, unexposed film looks like after processing. Since no X-ray exposure has happened at all silver halide crystals are removed during fixing. The base of the film is left, which is clear with a slight blue tint. Fourth option, completely clear. So this could be a technically correct if the film base has no blue tint. Some older or cheaper films can give you this representation. But now these days modern X-ray films have a blue base to reduce the eye strain and improve the contrast. I can show you the pictures. The first one is completely black. Second one is cloudy with a blue tint. Third is clear. Fourth is completely clear. The fourth question, the very important question. You should focus on what I am teaching and involve with me. A female patient who is otherwise healthy visited the clinic for a skin treatment. Let's highlight the points, important points here. A female patient. I told you, sometimes the predilections is very good to eliminate the wrong options. A female patient, otherwise healthy, visited the skin clinic for skin treatment. The dermatologist observed ulcers at the commissures of the lips. What are commissures of the lips? If you can see my video here, commissures of the lips. She revealed that she also had such ulcers in the past as well, and it is a frequent affair. Frequent is an important word here. History, past history as well. The ulcers are also painful in nature. Identify the condition. Ulcers are also painful in nature. Identify the condition. Yeah, The first option is herpes zoster, recrudescent herpes simplex, third is herpangina, fourth one is erythema multiforme. Yeah. So, coming to the options one by one. I'll explain you by choosing the first correct option only. The second option, which is the answer to this question, recrudescent herpes simplex. Nothing but a reactivation of herpes simplex virus, HSV1. It follows a primary infection, which might go unnoticed or mild. Triggered by stress, fever, sunlight, trauma, occurs at same time repeatedly, mostly at the commissures of the lips. Painful, grouped vesicles that may rupture and causes ulcers while crusting. Heals within 7 to 2 days. Oral features are ulcers on the lips as well as hard palate. Occurs outside also the mouth. Extraoral, it can occur outside the mouth as well, but here we have to discuss about the intraoral features only in this question. So not discussing about extraoral features. Second one is herpes zoster. I'll give you very good trick to remember these about these. So please, if you want to take the screenshot of the slides, you can. If you want me to wait, you can let me know. Because I am very much confident about my slides, about my preparation. It is very good, very informative. If you want me to stop somewhere, if you want me to give a brief recap, I can. But just let me know. Next is herpes zoster. Shingles caused by varicella zoster virus, VZV virus, the same virus that causes chicken pox. It is seen in older or immunocompromised patients. Lesion shows dermatomal pattern, unilateral distribution. You will see the half portion of your face is affected. A zone is created. Just a zone is created. A unilateral zone. Zone, mark the word zone is created. Zone is created. Then go for option zoster. It is a good way to remember, I guess. Zoster, a zone is created. Next, lesions, this way I have already done. Yeah, associated with severe pain, burning, paresthesia. Oral features include unilateral vesicles, ulcers on the palate or tongue, may involve trigeminal nerve branches, not recurrent. Again, a very good thing to point, not recurrent. The question it was asked as, it is recurrent. Past history, the girl was giving the history of past as well. But in herpes zoster, unilateral distribution and then not recurrent. So eliminate this from the options. Third is herpangina. Herpangina caused by Coxsackie A virus, commonly in children, lesions on the soft palate, tonsils and uvula. Fever, sore throat, dysphagia, difficulty eating are very common. Oral features include small vesicles seen on the soft palate. In HSVs, herpes simplex virus, we saw the features, the ulcers on the hard palate. But now here we are seeing the ulcers on soft palate. No lip involvement. Again, in the HSV virus, the lip involvement was seen on the commissures of the lip. Great. These are the very important points. Again and again, I am repeating the same thing. Again, very important points to eliminate the wrong options if you don't know the correct one. The best thing to do in the exam is just eliminate the things you know. Next is erythema multiforme. Hypersensitive reaction due to some drug infection or drugs or infections, anything else. Sudden onset, more dramatic. Target lesion on the skin. Target lesion, bullseye appearance. If you know what is bullseye appearance. Do anyone knows? I'll wait for you guys. What is a bullseye appearance? Target lesion. If anyone knows, I would be glad that my students are participating in the session. I'm waiting for you. What is a bullseye appearance? Or can you name a game, a very common game people play, which appears this target lesion, bullseye appearance? No? So yeah, darts game. Dart. Yeah, dart game. So, in erythema multiforme, a characteristic bullseye or target lesion is seen. This lesion appears as round, flat, red patch with a dark dusky center. Pale red rings around it. Dark dusky center, pale red or yellow rings around it, resembling a dartboard. The lesions may develop a central blister or scab and are often symmetrical, appearing on the extremities, hands, feet, and sometimes the face or lips as well. Oral feature includes widespread painful ulcers, hemorrhagic crusting of lips, can mimic herpes but usually more severe, and systemic symptoms are associated with it. Yeah, it was what I was discussing. I will give you the mnemonic to let you know, to learn the things better. Recrudescent herpes, repeated herpes. Remember this way, recrudescent herpes, repeated herpes, corner of the lips, painful, zoster, zone is created, only one side. Herpangina, kids, soft palate. Erythema multiforme, many ulcers, multi-ulcers along with crusting of lips. Just take the screenshot of this slide. Just take it. I'll wait. Very important slide. Next, I'll show you the images. What you can say is ulcers on the soft palate. What was that? Herpangina. Next image, herpes zoster. In herpes zoster, what it is? A unilateral thing is seen. A unilateral lesions is seen on the palate as well as on the extraoral features. Zone is created. This is herpes zoster. Next is erythema multiforme. You can see the lesions on the lips, and in the next image as well you can see on the lesions on the lips, but they are on the commissures and they are seen everywhere on the lips. Hemorrhagic crusting, more severe. So the first image is of erythema multiforme and the next image is of recurrent herpes. Yeah, I have got a reply from Shibani Padi. Yeah, central lesion surrounded by concentric ring. Very good. I am really impressed by Shibani. Actually, she is participating. Very good. Yeah, Shibani, I'll let you know again. A round flat red patch with a dark dusky center with the pale red rings around it. Seen in erythema multiforme. The next question on your screen. A young man with a carious molar reports, let's start highlighting the things. A young man, carious molar, reports with long-standing mild pain, long-standing as well as mild pain, swelling with respect to tooth on the buccal side, here sometime. Radiograph shows new bone formation below the periosteum. Radiographic shows new bone formation around the periosteum, below the periosteum. This condition is known as acute osteomyelitis, Gary's osteomyelitis, chronic osteomyelitis, and subperiosteal rarefaction. Don't worry, I know these words are difficult to understand. What is osteomyelitis, what is acute osteomyelitis, what is Gary's, what is chronic, what are these things, ma'am. I'll make you clear each and everything. Don't worry. Coming to the correct option first. The answer is Gary's osteomyelitis. Yeah. Also called as proliferative periostitis. So just don't learn the question, don't learn the answer, because the examiner might give you the option proliferative periostitis in the next exam with the same question. Now then you will come and say, ma'am, you didn't teach us what is proliferative periostitis. But students, I am teaching you. Proliferative periostitis is nothing but the other name of Gary's osteomyelitis only. Okay, so Gary's osteomyelitis, also called as proliferative periostitis, happens mostly in children and in young adults. Low grade chronic infection, chronic infection. If you remember in the question, they asked about the long standing mild pain. So the chronic infection, like from a carious molar or something else, causes stimulated periosteum to lay new bone. It means body is trying to wall off the infection. Body is trying to lay down a new bone. In X-ray, it will feature as onion skin appearance. Just take the screenshot of this as well. Onion skin appearance. Layers of new bone formation under the periosteum like a skin of onion. First layer is stripped off and then we have got the second layer, then you got the third layer. First option was acute osteomyelitis. The name is itself suggesting acute, not chronic, not long-standing infection. Sudden onset of bone infection, usually bacterial. Sudden onset. Severe pain, swelling, fever, pus formation, loosening of teeth might be associated with it as well. No new bone formation. In early stages, no new bone formation is seen. But in the question, they were asking about the new bone formation below the periosteum. In X-ray, initially it is normal, but later it shows the bone destruction. Next, we have chronic osteomyelitis. Long-term infection of the bone. Might cause pain, pus, draining sinus, and bone destruction. Here, the important thing is bone resorption is very much, the rate of bone resorption is very much than the new bone formation. X-ray appear as irregular bone loss. Sclerotic areas are also seen. Fourth is subperiosteal rarefaction. Seen in conditions like hyperparathyroidism, it is bone for resorption under the periosteum, not the new bone formation. Usually affects the long bones, not related to dental infection. It is somewhat associated to femur, the thigh bone, yeah, but not usually related to our dental infections. Again, we have a trick to remember, how to remember. Gary's osteomyelitis is growth of bone. New bone is formed in the form of layers. Onion skin appearance. Acute, generally aggressive infection of the bone. Chronic, cranky old infection. Rarefaction, reduction of bone losses seen. The sixth question. A patient complains of repeated attacks of pain in the ear and the tonsillar fossa. This is the characteristic of. Here I have got you the next question as well. I'll show you. But just mark the important things here. A patient complains of repeated attacks of pain in the ear and the tonsillar fossa. Repeated attacks in the ear as well as tonsillar fossa. And in the next question, very next question, a middle-aged female complains of electric shock-like pain electric shock like pain. Electric shock like pain. I think my marker is not working. In the cheek region, which occurs for only 2 minutes. In between the episodes, she has no pain. Electric shock like pain in the cheek region, and in between these episodes, she has no pain. This is mostly. So, can someone answer in the chat box what is the answer to this question? I will wait for as long as you want me to wait. What is the difference here? Repeated attacks of pain in the ear and in the tonsillar fossa. And the next question is electric shock like pain in cheek region. So I will mark the correct answer here. Repeated attacks of pain in the ear and the tonsillar fossa. The answer is glossopharyngeal neuralgia. And for the next question, the answer is trigeminal neuralgia. Let's learn the slides options one by one. Again, I am very confident about these slides. Again, I am repeating the same thing. Trigeminal neuralgia involves the trigeminal nerve, the fifth cranial nerve, the main sensory nerve of the face, characterized by sudden stabbing electric shock like pain. The patient can't tell you, he or she will come into a dental office and complain of a toothache. The dentist might start with extracting the teeth. He or she will get all of the teeth extracted from the affected side. And then also she'll explain you the same problem. Ma'am, I'm still experiencing the same pain, electric shock like pain. So the explanation is it is a neuralgic pain, trigeminal neuralgia. And the correct medication for this is mezitol. Involves trigeminal nerve, the fifth cranial nerve, characterized by sudden stabbing electric shock like pain, usually affects the face, usually the cheek, jaw and around the eye, triggered by touch, chewing, speaking or even wind. No pain in the ear or in the tonsil area. Second, glossopharyngeal, which was the answer to this question, involves the glossopharyngeal nerve, which is our ninth cranial nerve. Pain is felt in throat, tonsillar area, base of the tongue, ear and the jaw angle. Often triggered by swelling, coughing or speaking. Pain is sharp, shooting and sudden, just like trigeminal neuralgia, but in different locations. Trigeminal neuralgia, it involves locations like cheeks, jaws, and even if the border of the eye. But in glossopharyngeal, if the glossopharyngeal neuralgia occurs, the pain is seen in tonsillar area. The third is the sphenopalatine neuralgia, also known as Sluder's neuralgia. Affects the sphenopalatine ganglion. Pain is felt deep in the face, around the nose, behind the eyes or upper jaw. May also be accompanied by tearing, nasal stiffness and red eye. Not associated with ear or tonsillar pain. Not associated with tonsillar pain. So again, I'll repeat the next question. A middle-aged female complains of electric shock-like pain in the cheek region, which occurs for only 2 minutes. In between these episodes, she has no pain. No pain is seen. Yeah. Electric shock-like pain is a symptom of trigeminal neuralgia. Next question is, growth hormone is not released in the following conditions. The options are NREM sleep, glucocorticoid therapy, hyperthyroidism, and puberty. Before starting with the correct answer, before telling you the correct answer, I would like you to know all the options. What is NREM sleep? What is REM sleep? Because it is a good question of physiology as well. Yeah, starting with NREM sleep and REM sleep. Just giving you the brief, your brain is super busy during REM sleep. It's like your own movie theater, which is bringing you with the crazy dreams. NREM sleep is like your body's repair time, when the muscles and tissues are growing and get energy is getting restored. Brain is super busy creating the vivid dreams during REM sleep, but during the NREM sleep, the body is getting its repairing time to restore the energy used. Here is the beautiful difference given between the REM and the NREM sleep: rapid eye movement sleep and non-rapid eye movement sleep. Eyeball moves quickly, eye stays still. Body, most vivid dreams, less dreaming. Brain is almost paralyzed. Body can move a little, like turning, like, yeah. When it happens about 90 minutes of after sleep. And when does NREM sleep happens? Right after falling asleep. Got it? Yeah, it is written same here. Growth hormones is primarily secreted during NREM deep sleep, especially between the stage 3 and 4. That's why proper sleep is essential for growth in children. So NREM sleep promotes growth hormone release. It is important in children. Glucocorticoid therapy, which is the correct answer to this question. Medications like prednisolone, cortisol are nothing but glucocorticoids only. They suppress the growth hormone release and opposes its effects. So long-term steroid use can slow down the growth in children. That's why we say we should not use steroids much in our practice. So glucocorticoid therapy inhibits the growth hormone release. Third option is hyperthyroidism. In hyperthyroidism, metabolism is increased. It may modestly reduce the growth hormone but does not completely block it. Growth hormone response might be blunted, but secretion still occurs. So, growth hormone is not completely absent in hyperthyroidism. Puberty, one of the peak periods of growth hormone release. Sex hormones, especially estrogen and testosterone, stimulates growth hormone production. That's why children experience a growth spurt during puberty. So puberty strongly increases the growth hormone release. Next question is on the screen. Brunner's gland are found in kidney, duodenum, ileum, and colon. The answer is very much clear to you all, I think. Can you answer? Someone answer to this question? Very easy question. A proper theoretical question. The answer is duodenum. The Brunner's gland are special glands found only in the duodenum, which is the first part of small intestine right after the stomach. Think of them like the bodyguards that protects the inner lining of the duodenum, because the food after coming from the stomach, what happens is it gets mixed with the strong acid there. Which acid? Hydrochloric acid. The Brunner gland makes a thick alkaline basic mucus that helps to neutralize this acid so that the walls of the duodenum does not get damaged. Here's a quick way to remember. Brunner's gland is equal to buffer system. It neutralizes the acid which is caused due to the HCl present in the stomach. Next, during which phase of menstrual cycle are progesterone levels the highest? First is between ovulation and menstruation, during LH surge, transition from follicular antral stage, before ovulation. Before starting with what the answer, before explaining the answer, I would like to explain what are the phases of menstrual cycle. Yeah. The menstrual cycle has four main phases: menstrual phase, follicular phase, ovulation, and the luteal phase. The first is menstrual phase, where the period actually happens. And then we have follicular phase. Egg is growing. Ovulation. Egg is released. Luteal phase, after ovulation, body prepares for pregnancy. Body prepares for pregnancy. Let's starting with the menstrual phase. First is day 1 to 5. Day 1 to 5, what happens is the uterus lining sheds. This is actually when the period comes. This is actually your period. Hormone levels is estrogen low, progesterone low, FSH starts to rise, LH low. And second, follicular phase, the day starting with 1 to 13 overlaps with menstruation. What happens is follicles, eggs in the ovary starts to grow under the effect of FSH. The one of it becomes dominant and matures. Uterine lining starts to rebuild. Hormone levels like FSH starts rising, estrogen rises, LH stays low, but it keeps rising slowly. Progesterone is still low. Key point is estrogen is actually a star here. It thickens the uterine lining to prepare for any upcoming pregnancy. Third is ovulation around day 14. What actually happens is a mature egg is released from the ovary due to sudden spike in LH. In what happened in follicular phase, the LH is slow but is slowly rising. And in the ovulation, there is a spike in LH surge, which causes the actual ovulation. FSH, small increases seen, estrogen peaks just before the ovulation, progesterone starts to rise slightly. Key pointer here is LH surge is equal to egg release. Ovulation typically happens about 14 days before your next period. Not always the day 14, it may change body to body. Next is luteal phase. What happens is after ovulation, yeah, Shivani, I'm getting a good response from you and I'm really impressed by your preparation. You're really impressed. I need all responses from rest of the students as well. Good. Luteal phase. What happens is after ovulation, the leftover follicle becomes the corpus luteum and start producing progesterone. This prepares the uterus for pregnancy. Hormone level, progesterone highest, estrogen moderate, LH and FSH drops down. Here I have drawn a very good table for you to remember how to remember these hormones, when they rise, when they come down. So starting with the letters FELOP. Fallope. Hormone FSH, estrogen, LH, ovulation and progesterone. Timings: early cycle 1 to 5. Estrogen, what does it rise? Follicular phase. LH just this day before day 14 because it helps in ovulation. Ovulation around day 14. Progesterone, luteal phase. It prepares the uterus lining for any upcoming pregnancy for implantation. FSH first stimulates follicular growth. Estrogen thickens the uterus lining. LH surge triggers ovulation. Ovulation, egg released. Progesterone prepares uterus for implantation. Very important diagram, please, very important table. Just get the screenshot clicked right now. Next question is, maximum reabsorption of water takes place in which part of the nephron? PCT, DCT, collecting duct, all of the above. Actually, the reabsorption of water takes place in everywhere in the nephron. But they are asking about the maximum reabsorption. The answer to it is PCT. But I'll explain all the options as I discussed in the early part of this session. I'll be explaining all the incorrect ones also. Coming to the option 1, PCT, proximal convoluted tubule. This is where the most water is reabsorbed, around 65 to 70%. It reabsorbs water with important substances as well, like glucose, amino acids, sodium, etc. Water follows these substances by osmosis. Happens automatically. No hormone is released. No hormone is needed there. I will tell you about the antidiuretic hormone which is used in the collecting duct to reabsorb water. I will explain you that as well. Next option is loop of Henle. Descending loop of Henle is more reabsorbs water. The ascending loop of Henle is completely impermeable to water. No water is reabsorbed here. Third is DCT, distal convoluted tubule. Reabsorbs a smaller amount of water, controlled by hormones like aldosterone. Fourth is collecting duct, reabsorbs water only if it is needed. Controlled by antidiuretic hormone. Saves water when the body is dehydrated. So this is glomerulus Bowman's capsule. This one is I hope my marcus is visible. This one is proximal convoluted tubule. This is loop of Henle. This part is known as descending loop of Henle and this is known as ascending limb of Henle. This is distal convoluted tubule and this is collecting duct. The major amount of water is reabsorbed in proximal convoluted tubule only, along with some glucose, amino acids and sodium ions. Next, descending loop of Henle, permeable to water. Ascending is impermeable to water. It only absorbs the salts, nutrients here. Distal, it reabsorbs water but under the action of aldosterone. Collecting duct also reabsorb water under the action of antidiuretic hormone. When the body needs water, it starts reabsorbing it from the collecting duct. Next is reverse architecture is commonly seen in. Reverse architecture. So, important question, important topic of our periodontics. What actually happens is, if I draw the tooth here, this is my tooth. Again, I am repeating, my drawing is very bad and moreover I am explaining it on the laptop. So, drawing here is little tough, but I'll try to explain best I could. Yeah. What actually happens is, this is our interdental bone, the bone between the two teeth. And this is our radicular bone. What actually happens is, interdental bone is above the level of radicular bone in normal situations. The interdental bone is above the level of, my marker is not working here. above the level of radicular bone. But what happens in reverse architecture? Yeah, it is written. Now, in normal healthy bone around the teeth, the bone between the teeth, interdental bone, is higher than the bone on the sides of radicular bones. In reverse architecture, this pattern flips. The radicular bone is higher than the interdental bone. The bone looks like it is reversed. This usually means the bone loss between the teeth, often from the excessive force. The first option, which is the correct option, TFO, trauma from occlusion, happens when too much of excessive force like chewing, grinding, clenching is placed on tooth. This pressure can damage the supporting bone, especially between the teeth, leading to the reverse architecture. No plaque or infection is needed. This is a mechanical problem. Aggressive periodontitis. What happens in aggressive periodontitis? A rapid progressing gum disease is usually seen in younger people. Bone loss is often vertical and localized, especially around the first molars or incisors, not typically described with reverse architecture. Osseous craters, a ball-shaped bone defect between two teeth. Bone loss happens on the inner side of both teeth. It's not reverse architecture, but it is common in periodontal diseases. Food impaction happens when food gets stuck between the teeth due to open contact, fillings, etc. Can cause localized gum irritation, gum swelling, but usually leads to gingival inflammation or interdental papilla damage. No reverse bone patterns. Next question is, GCF secretion does not increase in which of the following? First is TFO, smoking, toothbrushing, and diabetes. Can anyone know? Tell me if anyone knows what is GCF, why it increases, in which case it will increase, in which case it will decrease. Yes, anyone? GCF, gingival clavicular fluid. It is a fluid that comes out of the space between the tooth and the gum. It increases when there is inflammation or mechanical stimulation like brushing or trauma. Important point is, it increases when there is inflammation, mechanical stimulation like brushing or trauma. TFO, too much biting force can irritate the tissue around the tooth. This mechanical stress can cause mild inflammation and increase in GCF. Smoking reduces the blood flow to the gums. So even if there is a gum disease or inflammation, the body's reaction is suppressed. It is like a silent disease. GCF does not increase much even though there is a damage. Toothbrushing. Brushing stimulates the gums even more so if done roughly or too hard. This temporary mechanical stimulation causes a rise in GCF. Diabetes. In diabetes, the patient has a higher inflammatory response. Even a mild gum irritation can lead to more GCF, especially in poorly controlled diabetes. And next question, when a new periodontal fibers attached to new cementum with a new gingival attachment. Very good question, very important question, very repeatedly asked in the exams. New periodontal, again new cementum, new gingival attachment, the procedure is called. Obviously the answer will be new attachment. Every word is here new, the answer will be new attachment. So let's just read one by one what is reattachment and what is new attachment. What happens in reattachment? This happens when the gum tissue attached back to the tooth in an area where there was no disease before. The gum tissue was completely normal, no disease was there. Think of it like lifting a flap during a surgery and then putting it back in a place. The tissue just goes back to where it was. No damage or infection was there earlier. So it was an option of reattachment. You lift a flap during a surgery and then putting it back in a place. New attachment, this is when the gum and the bone tissues attach to the tooth in an area that was previously damaged by disease like periodontitis. It's like the body is making a brand new connection with the tooth and the supporting tissues. This is more complex and involves healing in a previously infected area. So the question was asking about new periodontal fibers, new gingival attachment, new cementum. So answer will be new attachment. Sorry. 15th. Toothpaste component responsible for remineralization of tooth. Give me a second, please. Toothpaste component responsible for remineralization of tooth is CPP, ACP, dentifrices, thymol, licorice. The correct answer to this is CPP, ACP. This is much theory-based question, but as discussed earlier, I will let you know each and every option in a better way. When your teeth loses minerals like calcium and phosphate, they start to weaken up, and that's the beginning of cavities. Remineralization means replacing those lost minerals and keeping your enamel strong. So the answer, as I already told you, CPP, ACP, casein phosphopeptide amorphous calcium phosphate. It's a milk-derived protein combined with calcium and phosphate. This combo sticks to the tooth surface and slowly releases calcium and phosphate, helping in rebuilding a enamel. Dentifrice is general term used for any toothpaste or tooth cleaning product. It may or may not contain remineralizing agents. What is Colgate? What is Close-Up? What is Dantkanti? They all are dentifrices. They may or may not contain remineralizing agents. Thymol, a natural antimicrobial, comes from a thyme plant used in mouthwashes like Listerine. You can see the components of the Listerine mouthwash. You can see thymol written there. It is what? Antimicrobial agent. Helps in plaque control but does not remineralize the tooth. Licorice. Licorice is used in some Ayurvedic products. A natural herb with a anti-inflammatory and antibacterial properties. Herbal, it is seen in herbal toothpaste. The next question of orthodontics. Which of the following statement is false in relation to the bird face deformity? Before starting with the options, before starting with the question as well, I would like to tell you what is a bird face deformity. Bird face deformity is term used when someone has lower jaw and a prominent upper jaw. Lower jaw is smaller than the upper jaw, making the profile look convex like a bird's beak. Like a bird's beak. Like somewhat like this. Bird's beak. You can see in this diagram as well. Bird's beak appearance. So what are the possible reasons for this? Class 2 malocclusion means the upper teeth or jaw are ahead of the lower ones. The second reason, retrognathia. Retro means backward. Gnathia is jaw. Retrognathia means the lower jaw is placed backward or underdeveloped, which means the upper jaw is more developed. It will lead to the bird face deformity only. More Frankfurt mandibular plane angle. FMP plane angle tells about the angle which is between the base of the skull and the lower jaw. I will show you the diagram as well. Base of the skull and the lower jaw. In the bird face deformity, the lower jaw goes downwards and backwards, which makes the angle larger. More posterior facial height. Posterior facial height refers to the height of the back of the part of the face. In bird face deformity, the lower jaw is underdeveloped. And the downward rotated, leading to the reduced posterior facial height. Instead, the anterior facial height is usually more in these cases. Next question is, which of the following appliances can be used for non-surgical treatment in the patient which shows definite pre-surgical improvement? I guess the image is missing here, but I will show you. They were asking about this case, a case of cleft lip and cleft palate. They are asking about the non-surgical treatment. The option given here are oral screen, nasoalveolar molding appliance, obturator, and the Frankel appliance. The answer is nasoalveolar molding appliance. Oral screen. Oral screen, not for cleft repair, just for habits, for thumb sucking habits. Yeah. Obturator helps after the surgery or when the surgery is delayed, mainly for feeding and speech by closing the opening. If someone has cancer of the palate, the site is cleared from that, the palate area is incised. You can see in this image, the obturator is given to the patient, which helps in the patient before in speech and eating. This is the example of oral screen. And the third one is the Frankel appliance, used for jaw growth correction, not for cleft pre-surgical molding. Here is the Frankel appliance. You should know the correct the images as well, because image-based questions are very frequently seen in today's scenario. This is obturator, this is oral screen, obturator, and the Frankel appliance. And this is nasoalveolar molding. It is a pre-surgical orthopedic appliance used in infants with cleft lip or palate. It helps in molding the alveolar ridge and nasal cartilage. It reduces the cleft gap, improves symmetry. NAM is also a non-surgical method that shows definitive pre-surgical improvement in shaping and structure of cleft area. 18th question, movement in which the force act on full space PDL, not a point. Not a point. Then again mentioning not a point, a full force act on a full PDL space. Options are rotation, bodily movement, talking, and tipping. I'll explain you. What is rotation? You can see my hand, right? I think you can see my hand. If my screen is visible. What is rotation? The tooth spins around the long axis like a doorknob. Doorknob. What happens in doorknob? 1, 2, 1, 2, 1, 2. This is rotation. The main force acts as the center of the tooth's root, causing it to twist inside the socket. Force is concentrated on a small area, not the entire PDL space. The next is bodily movement. What it is? The tooth moves in the same direction without tilting or rotating. That's like translating. Force is applied evenly along the whole length of the root and transmitted around the entire PDL space. Third option, talking. This is a special kind of movement where the root tips moves but the crown almost stays fixed. If this is the crown and this is the tip, the root tip moves but the crown is almost fixed. How could I show it? Let me explain it to you. Root tip moves but the crown tries to stay almost fixed. Only the root tip is fixed. Only the root tip is moving. Force is applied at the root apex, causing it to tip inside the socket, but does not move bodily. Tipping, what happens in tipping is the tooth tilts around and near the tooth, so the crown moves more than the root. Both crown and roots are moving, but the crown is moving more than the root. Like leaning of tree onto one side, leaning of tree onto one side. Next is Wallerian degeneration is seen in nerves, muscles, bone, tendon. Anyone knows this answer? Do anyone knows? Nerves. Answer is nerves. It is a process that what happens after a nerve is injured or cut. The part of the nerve fibers away from the nerve cell body that gets disconnected from the main cells starts to break down and cleans up by the body. Here you can see a very good diagram of Wallerian degeneration. Injury has happened, the part is cut down and breaks down into the pieces. Injury happened, the part breaks down and is broken down into pieces and is cleaned up by the body. Where is Wallerian degeneration seen? When a nerve fiber is damaged, the part separated from the nerve cell body undergoes Wallerian degeneration. The axon and its surrounding myelin sheath breaks down. Next question. What happens with systemic toxicity of LA, which we usually give in our daily practice? Post-convulsion depression, post-depression convulsion, convulsions and depression. Very good question and also a confusing one. When too much local anesthetic gets absorbed in a bloodstream instead of working just locally, it can affect the CNS and the heart. Local anesthetics first excites the brain and then causes it to depress. First excites the brain and then causes it to depress. Initial excitation, which means convulsions are seen, and then it is followed by depressions. The very first sign of toxicity is usually convulsions. Again, important point, the very first sign of toxicity is usually convulsions. Why does this happen? This happens because LA blocks the inhibitory nerve signals. So the brain becomes hyperactive, overactive, and causes much muscle twitching and seizures. It followed by depression. After these convulsions, the brain's activity slows down, leading to depression of the CNS. This means that the person may become drowsy, lose consciousness, breathing may slow or stop. So the correct answer is post-convulsion depression. So the correct answer is post-convulsion depression. Yeah, the 21st question. Marginal resection refers to resection without mandibular discontinuity, resection with mandibular discontinuity to create a window in the bone, resection with normal bone margin. Marginal resection is a type of surgery done to the jawbone, especially mandible, to remove a disease like tumor or infection. In this surgery, what happens is the diseased bone is removed, but the continuity of mandible is kept intact. A very important line. Very, very important line. What happens in this surgery is the diseased bone is removed, but the continuity of mandible is kept intact. This means the outer space of the jaw, shape of the jaw remains the same. There is no break, no gap in the bone after surgery. Only a thin margin or slice of the bone at the edge of the margin is removed to get rid of the disease. To get rid of the disease. So the answer will be resection without mandibular discontinuity. Resection without mandibular discontinuity. Next we have dull throbbing pain is caused by C fibers, alpha fibers, beta fibers and delta fibers. Again, I have a very good diagram, good table to show you. Fiber type, if they are myelinated or not, what is the speed, what are their functions. Here we have C fibers, no myelination is seen, speed is very slow. It is the reason for dull throbbing pain and maybe pain due to temperature change. A delta fibers, sharp acute pain. A beta fibers, touch, pressure and vibration. A alpha fibers, motor control, proprioception, touch and touch receptors basically. So the correct answer is dull throbbing pain is caused by C fibers. Take the screenshot right now. Very important. Next, crowding in maxillary anterior teeth and with posterior crossbite is due to crowding in maxillary anterior teeth, somewhat like this. Crowding in maxillary anterior teeth. Crowding is seen. And posteriorly crossbite is seen. They are asking about the cause. What happens in maxillary anterior crowding? This means the upper front teeth, incisor or canine, do not have enough space so they can become crooked, deformed, or rotated or overlap each other. It's look like many people are trying to fit in small elevator and there is no enough room. So what will happen? The one person will rotate to one side, other will overlap each other, right? So what happens in posterior crossbite? This happens when the upper back teeth bite inside the lower back teeth. Upper ones bite inside the lower ones instead of outside, which is normal actually, right? What happens in normal way? The upper teeth bite outside the lower back. But what happens in crossbite? The upper teeth bites inside the lower back. It can affect one or both sides. It may be due to narrow upper jaw. What are the causes? Tooth-jaw mismatch. If their teeth are too big, jaw is too small to accommodate all teeth. Delayed loss of baby teeth. If the permanent teeth does not get enough time to enough space to erupt, leading to overlap. Extra teeth, supernumerary teeth, can block normal eruption and cause crowding. Prolonged thumbs upping or pacifier pushes teeth out of the place and affects jaw. Genetics, family history of crowding teeth. Causes of posterior crossbite. Posterior crossbite is seen as narrow upper jaw, maxillary constriction. The upper jaw is too narrow to fit over the lower teeth. Mouth breathing affects the normal development of the upper jaw, making it narrower. Prolonged thumb sucking pushes the upper teeth inwards, creating a pressure on the teeth, and lower teeth outwards. Skeletal discrepancies. Jawbone growth unevenly. For example, smaller upper jawbone and a wider lower jaw. Early loss of primary molars can shift the bite and lead to crossbite. Next, which appliance is shown here? Lingual arch, transpalatal arch, bilateral band and loop, bilateral crown and loop. Lingual arch. Where is it used? Obviously lingual. Lingual word is not used for the maxillary arch, right? But here they are showing above the maxillary teeth. So why will be this the option, na? It is very clear. Just eliminate this. Lingual arch, lower mandibular arch, where what it looks like a wire runs along the inside of the lingual surface of the lower teeth and connects bands on the molars. Purpose, it holds the position of the lower molars and helps them from drifting forwards. Used when multiple lower teeth are missing. I have the image as well. This is lingual arch. Lower multiple teeth are missing. It helps it prevents the molars from shifting forward. Next we have transpalatal arch, which is our correct option. Upper maxillary arch, a wire runs across the roof of the mouth, palate especially, and connects the upper molars. Purpose, it keeps the molars in place, prevents them from rotating or tipping, used when molars are bended and other teeth are still present. Third, bilateral band and loop. Bilateral band and loop. This upper or lower jaw, what it looks like, it has bands on two molars, one on each side, and loops extending forward to hold the space for missing teeth. Purpose, it maintains space when multiple teeth are lost on both sides. Take the screenshot again and again. I am repeating, please take the screenshot, they are very important. Bilateral crown and loop. Where it is used, upper or lower arch, what it looks like, similar to band and loop, but instead of bands, it uses the crowns on molars, stainless steel crowns to support the teeth. You can see the image, the stainless steel crowns and with a loop around the missing teeth. Purpose, used when molars are badly decayed, can't support a band, so crown is given instead. Last question for today is Koplik spots are seen in. Where are Koplik spots seen? Koplik spots are seen in bacterial infection, viral infection, fungal infection, and HIV related manifestation. As we are progressing towards our last question for today, I want responses in the chat section. I need responses if you have any doubts. If you have any doubt, just drop it in the chat box. Koplik spots are small bluish white spots with a red background, usually seen inside the cheeks, buccal mucosa, opposite the opposite the lower molars. They look like a tiny grain of salt or white sand on a red surface. These spots appear before the skin rash in child with measles. They look like somewhat this. The answer is very much clear here, and that's all for today. I hope I have given you good explanation, and still if you have any doubt, you can comment in chat box. I am available till you want me to be here. Please, if you have any doubt, please mention in the chat box. Any doubt, any doubt. I would be glad to entertain your doubts. This way, not only yours but also my knowledge will increase. Maybe I won't be able to give you the answer right now at the right same spot. I'll also have to go through some books. But yeah, I need responses. But not getting any responses means no doubt. So let's end this session here only. Thank you so much for today. Yeah, thank you so much.